been a long journey to get here. Someone said, start with an exit plan. I had a comment from this side of the room. Every project should start with an exit plan. And we hope that as inSupply, that is something we're going to take up even to the rest of our partners. As we start projects, what's the exit plan? Are we building on KHIS? Is the ITT working independently? Are impact teams something we can actually use? I absolutely like what has been done in Samburu, where it's already in the budget. I know Turkana was looking for how to put this in the budget. Where is Dalmas? How to put the CHV allowances. It can be done, okay? And let's keep motivating them. We did a lot of sticky notes in the morning, and some ideas are coming up as questions, comments, even as we had tea and lunch. We have put them all here. Again, as inSupply, co-creating. We want to create together, because when we create together, then we own it, we sustain it, and we move in whichever county we are coming from. All right, so what future opportunities do we have? I'll start with key takeaways. It is great the way CHVs are motivated in Samburu, Varo, and cold chain. Someone talks to data, someone talks to himself, data talks to him. Wasn't that a good takeaway from one of the presenters that we had? All right. In Nairobi County, CHVs are already receiving a stipend. How did that happen? And I'm looking to Beatrice. Those best practices are the ones we'd like to hear, because then we can go and incorporate them in our counties and in our political arms, because we know that we work as one team, as Amos has rightly said right here. And then there'll be improved service delivery, which is happening. Someone else in the panel here said primary health care is the core of what future healthcare is going to be. So if primary health is strong through our CHVs, then we are going to make it. Start with the end in mind. Yeah? CSTOC has been incorporated into KHIS. So inSupply came in with an exit strategy 3 years ago, and here we are incorporating things. Thank you, Ken, for that one, starting with the end in mind. We need to align our interventions with the community health strategy. We need to run as one, not in parallel or antagonizing. We improve on it and see how to make it even better. How can we sustain innovations introduced by MOH and the partners? That sustainability we've talked about over and over. That's what the panel discussion was about. Supply chains focus on stock out rates, but to build a strong supply chain, we must invest in processes and people. How does it work? Without the people, we say no commodity, no program. And no people, no process, then we know how that goes.
The commodities for Samburu, we order through KEMSA and meds. It's nothing out of the ordinary. It's not special. We just know that the facilities, we do the catchment, we know the catchment population. We understand the mobilities in that population and the consumption data. So it's just part of the normal order request, but now we factor now that there will be increased access of health to the communities. So we actually bump up the quantities to cater for the increased access through the CHV engagement to the communities. So it's just part of the normal ordering process with a few tweaks here and there to factor in the uniqueness. And also we also look at the season. If it's a dry season, there are different illnesses. If it's rainy season, there are different sets of illnesses and factors like that. But it's just part of the normal ordering process.
Is it data-driven decision-making? Because you're factoring in everything else. That's really good. Thank you, Team Samburu. Team Siaya.
What was the motivation for reporting of the CHVs? As I said in the presentation, we had a section of CHVs that were actively implementing ICCM at the community level, with incorporation of CSTOC and every CHV being able to report what they have, what they don't have. Other CHVs also took it up because they felt when you report, you'll get commodities. If you don't report, you won't get commodities. So it was a good motivator at the end of the day that reporting well on a platform that was visible to all aspects of management from the facility up to the county was a good way for them to actually continue reporting on a regular basis. That was the biggest motivator. Then the feedback to the county government was that avail commodities at the community level, the person at the lowest level will be able to get a service without having to visit the facility. without any cost, and also minimizing on deaths that are common at some point in time when there is no care available. The impact teams at sub-county, there are some sub-counties that took it up very well, and there are some sub-counties that did not take it up very well. So in that specific sub-county, you find that the receipts, because they also have the highest number of CHVs in the county, they have 517 out of the 2,000. So they have like a quarter of the CHVs are in one sub-county. So there was also a change of leadership, change of staff. That kind of staff turnover is also affecting, and also the immediate supervisors. We had also new chairs that were employed, who are also deployed to that service delivery level. So currently is when they are being trained on aspects of ICCM. So that capacity building aspect was also another aspect that we could not do active follow-up, considering the large number of CHVs that they were handling at that time. But going forward, through the leadership of the county, we're expecting that there will be an improvement so that it comes across board for everyone to be able to get commodities. Thank you.
All right, still with the mic. One thing that I've heard is that you sold to the county that if we get this product, there's going to be less burden on health facilities, less visits, so lower costs. So that is already something we can already do in our respective counties. If this happens, then this will happen. Let's invest now for preventative as compared to, curative that costs. I want to take us back to question 3, please, which was Samburu and Siaya. How are commodities for CHVs ordered, and are they budgeted for separately in Siaya?
I'll just respond as per my counterpart from Samburu, because that is what we are also doing in Siaya. For commodities which trickles down to the CHVs is commodities which have been ordered for the link facility, but now there is that aspect of ensuring that community unit attached to that facility also is able to get a portion of this commodity which has come to the facility. So it follows the same channel, and these are basically the program commodities. Some of the commodities which are not under the program, like the zinc and ORS, are the ones which are under the county budget, which also get to reach to the community level. And also when we are budgeting, we budget for the facility, but taking into consideration the community unit attached.
The next slide is, I think, directed only exclusively to Team Turkana. So I'm looking around the room at our Turkana teams. Turkana, do you have reporting timelines? Which commodities are the CHVs distributing? Who procured the CHV phones? How are the CHVs motivated? Are the CHVs given a salary or stipend? Are there plans to scale up C-stock to other sub-counties? Those are a lot. So just from the presentation that you did, there was quite a bit and a lot of interest generated because Turkana and Loima is piloting hybrid paper to digital.
Thank you so much, Flora. Starting from the first one, do you have reporting timelines? Yes, we have reporting timelines. CHV should make sure that they report on 28th of every month. That is a timeline. And then at the facility, the report should reach the sub-county, HRIO, by 5th. That is like cross-cutting. We have timelines. And then B, which commodities are CHV distributing? We have a lot of commodities that CHVs are distributing, especially the ICCM commodities, beginning with the antimalarials, that is AL. With AL, we have also the RETs, the testing for malaria. CHVs are testing for malaria in Loima. They also have Paracet, tablets, although we don't have the disposable one, but we are using the tablets, the junior one. And we also have the antidiarrheals, that is zinc ORS, for prevention of diarrhea. So CHVs are distributing, and they are managing diarrhea at the village level. We also have management for malnutrition, because Loima is still a pilot for ICCM plus CIMAM. So we are doing that. We are still waiting for approval because we already completed the research. So the CHVs are still continuing with distribution of nutritional commodities, that is the RUTF and RUCF. And then we also have additional of dewormers. CHVs are distributing at the community level. We also have the water purifiers. CHVs have, and some CHVs have tetracyclines, ointments at the community level. We also have like male condoms. CHVs are being given to distribute at the community level. Sometimes we had sickle beads, where we give the CHVs and they do it very well, among other commodities. C, who procure the CHVs funds. It's courtesy of inSupply Health, though it's like the CHVs themselves procure their funds using their allowances during the trainings. So it's their own funds, they're not for inSupply. So it is through their training that they were supposed to get their allowances, then they did forego their allowances to have the future phones for them to own the phone and use them to report, to give, to have the CHS Act, Turkana County, I think around 2019. So the CHVs in Turkana County, they are getting a stipend of 3,000 per month. So we are among the first counties to have that act in place, and it's working now. There are plans to scale up C-stock to all sub-counties. Yes, that's our prayer. We will work together because the TOTs are there, the county TOTs, sub-county TOTs. We also have the Chvs as TOTs. So this is easily to be scaled up. Working with the county government, we are able to do that in partnership with other partners like Save the Children. Still, inSupply is there. We can work together to reach out to the all 7 sub-counties. Though even the 3 sub-counties, we are not 100%, but we still need to scale up. Why was C-stock not rolled out to all CHVs since you're the champions? Yeah, wow. Yeah, I know we are champions in C-stock, but through the management of the sub-county and the county, we are able, with the partners, to make sure that C-stock is rolled out to all the CHVs, even to because even the CUs that we had when C-stock started, there was like some kind of attrition. And we did like mentorship to the 3 new CHVs who were coming in. So we really championed, and all those people are reporting even now. So it's easier for us to do that in the whole county. Thank you so much.
Asante. That was a mouthful for Turkana. He deserves a clap, surely. So many questions for Turkana County. What is HP2D, George? In exactly 4 words, what is HP2D?
HP2D means hybrid paper to digital. Basically, taking a picture and sending the green button, your report is done.
Excellent. And there's a demo on the solution tables right there being piloted in Loima. So some of these counties, I know Dalmas is familiar with them and they should be addressed. This came through the online portal and was specific to George and to Turkana again. How do we get our stakeholders from the political arm involved in healthcare? All right? How do we ensure that these acts are passed? How do we get into the county budgets for healthcare to be prioritized at primary healthcare level, at community level? Resources, we need to budget for funding from the get-go. And when our budgets are in place, then it's about the spending all the way to community. When we put in an order for that facility, we put in for the community unit. So these are things that are already being done in our counties. Updated curriculum. So this was one of the ideas that is there. Whenever we update something, ICCM training is going on, let's update it and roll it out for everyone. Opportunities. Some solutions. I'm going to take us quickly through this. C-stock does not need a smartphone. Again, Ken said this. We are creating solutions for the user. We're creating not users for the solution. So the solution has to fit the user. I only have a feature phone, report on your SSD. There's no internet connectivity, report on your SSD. And there's all that's available. There are different digital tools at community level. How do we incorporate all this? Let's not be a me too. Let's see how we integrate those. And that is also work to us as partners. How do we move this forward together? That results in better data control, improved reporting. Co-creation of this process is going to get us at a different level. Indicator tracking tool, appraisal forms. I had Nairobi talking about this, and we monitor the targets and keep improving. Other opportunities, let's recognize our CHVs for the positive work that they are doing, all right? Because they are the face of primary healthcare for us all. Visibility of commodities at community level, and at the press of a button, someone said he sits in his office and he can see what's happening. Someone said he knew when Ken was showing him the ITT that those facilities had not reported because the impact teams had informed him that something was happening or not happening. CHA learning sessions, how are we supporting our CHAs? There's a lot of delegation that goes to them. How do we support them? Yes, we talk about CHVs quite a bit. What about the CHAs? Let's keep them in mind as well. Erratic supply of commodities impacts primary healthcare? Yes, it does. How do we make that different? There are ideas that have come around the room. Let's see how we can adopt those. Commodity availability enabled by C-Stock, we can see better what's happening at community level. I want to give a minute to Miriam. She has a few comments from around the room. Yeah. Thank you, Miriam.
The first one is for Nairobi, where they are saying tea and snacks, very good motivator for CHVs, or for the meetings. The second one is, I love the learning packages opportunity. Upload some of the modules, if not all, in the MOH Virtual Academy for visibility and usage by more counties. Thank you.
All right. Any other comments around the room? I can see some sticky notes.
So mine were just one or two questions or comments as they describe them now. The first one was, how have donors and partners mitigated political risk that has hitherto forestalled or interrupted health products and technology supplies, e.g. of FP commodities? What are donors and partners doing to ensure sustainability of program commodities, that is FP, vaccines, antimalarials, and nutraceuticals? A comment there, one cannot give what or no manage what they do not have. How can the public sector in health leverage on private health sector resources, platforms, and experience to promote health program item supply chain sustainability?
So I like that Amos is right next to you for him to take a crack at the first two, and Yasmin as well. I'll try the third one.
I think the first comment or question from my neighbor here is, what are donors and partners doing to ensure sustainability of program commodities? That's vaccines and other family planning and antiretrovirals and others. I think I'll take the side of vaccines. What partners and donors are doing to ensure sustainability of such, and of course try to discourage dependence on them, is we are trying to encourage governments or programs to plan using actual targets. What are you targeting to do? If I can narrow myself into vaccines, you go into micro-planning, starting from the lowest level. Somebody mentioned of bottom-up. Have those targets set from down there until the national level. Then you can focus and see what will be requiring in the next several years to come. Then look at what is available. You have been depending on, for example, Gavi for so long, and Gavi may very soon be pulling out. What happens when Gavi is not able to support the procurement of vaccines? Then you involve the government, Ministry of Finance, Ministry of Health, make sure that they start looking for resources to fund what is likely not to be available when the donors pull out. I want to give an example of those of you in this room. We have been running short of measles, we have been running short of BCG, these vaccines that are bought by the government. But for the past 2 years, you realize that those shortages are not there. Why are they not there? It's because the government has been involved. The Minister of Finance has been involved in planning. The Minister of Health has really involved the Minister of Finance, so that a budget is allocated for that specific item. And therefore, you can see the fruits coming out of that. So even if other donors again pull out with proper planning, looking ahead on what's happening, then you are likely to solve some of those problems.
Thank you, Amos. So again, it's the involvement of all stakeholders in making health a priority.
Great, and I think Dr. Macharia has a lot to say, so I'll keep mine short. My question was, how have donors and partners mitigated political risk that has hitherto forestalled or interrupted HPT supplies of FP commodities? I think it's a great question. All I can do is maybe comment a little bit on what I've observed, but not being a donor myself, please take this with as my opinion. What I have seen is an increased partnership approach with governments to try and say, is there a way we can meet you halfway? So for example, if you are able to put X in your budget, can we put Y in the budget? Can we match it? Can we do procurement that is based on some kind of data-driven forecast? Is there demand planning? So I think one of the examples we heard about in a different meeting was many years ago, Kenya had a budget line for procuring family planning commodities. And sadly, that got lost along the way. So I think there's attempts now to revive that concept, that commitment that Kenya was one of the first to show. And there's different leverage points that I think we see donors trying to do, one of which is promoting that joint ownership and partnership.
All right. Thank you, Yasmin. Dr. Macharia.
One issue that seems to be coming out strongly is an issue of leverage of private sector resource platform. And maybe for those of you who have not had the chance of going through our strategy, that is a supply chain strategy for division of health product and technologies. Issues of private sector partnership is very, very well articulated, because we realize that we cannot achieve universal health care without utilizing every available resource. A case in point is the rollout of anti-malaria, that is AL, through the private pharmacies, whereby the ALs are available at a subsidized rate of 100 shillings. And that has worked out very well, because in your local pharmacy, you walk in, for as long as you have a prescription, the price is known. While the actual cost of AL is well above 400 shillings. But through donor funding, utilization of private partnership, the product is available at your local pharmacy. I think because of the issues that seems to be posed to DHPT, we are a very young division, but with an elaborate pathway of where we want to go, and we are coming up with the programs that are going to support. There is an issue that was raised about donor project pulling out. We have already mitigated that. We are actually planning and doing budgets, and we are ready to take over. Before, issues have been approached in a we have not been involving the donor, the Ministry of Health at the time of exit. But now, where we are, any program which is coming to an end, we are ready. We have done quantification, we have done budget, we have forwarded the budget to Treasury for consideration, that this is the much that Treasury needs to put aside in the event a donor pulls out. There is the issue of consolidation of all quantification data. If you look at what has been happening in our country, every donor picks a product, does quantification, come up with figures which are not related to anything. So what we have decided as a division is to consolidate and do everything centrally, because a donor is providing AL. That is only one of the many HPTs which need to be provided to the people of Kenya. Therefore, if you go to press all the media houses claiming a success story, can we sustain this country by supplying only one HPT? We need to think outside the box. We need to address supply of HPTs in wholesome. Yes, you are doing a good job to supply anti-malaria, supply anti-TB, supply HIV products, but there are many other products that need to be put into consideration, quantification, so that we see and forecast. This is the amount of money that the country needs. In the event tomorrow Bill Gates withdrew from the HIV program, what would happen? We would go into a crisis. I believe from where we are, because we had not done that kind of quantification and identified the figures. If you look at from a national budget, HIV program takes an equivalent of 75% of our national budget. What would happen if they withdrew tomorrow? So we have already started mitigating and telling Treasury, this is what is going to happen. These are the scenarios. And in the event that happens, we are ready and we are set. Our prayers is it does not happen tomorrow. We would wish that it takes a few more years, so that we complete the budgeting process. We are going to get an engagement so that we take you through what DHPT are doing. I hope we are going to get some financing so that we have a sitting with all the counties, so that we talk about these issues, because they affect everyone. Initially, when devolution came, there was a feeling, oh, we are self-sustaining, but all of a sudden we have realized that there is a need for working together with the counties, because we are not competing with them, we are complementing them. Where there are gaps, we are there to support you. If we get a donor who is willing to do something with the county, we will shadow them to you, because we are not implementers. You are the implementers. Therefore, there is that clear understanding that anything about implementation should be handled with the counties, not with the Ministry of Health. I believe we will get another chance to articulate the issues, because they are many, they are heavy and weighty. Thank you.
Thank you so much, Dr. Macharia. Yes, I can see Judy clapping. That has shed quite a bit of light. There is another question to Dr. Macharia and one to Yasmin. I don't know if Yasmin has read hers and can answer. Or yes, please, Dr. Macharia.
There is a question which have been brought to my attention, and of course, it is the issue of KEMSA and KDF. Really, I truly would not be the best praised person to comment on this, because a decision was made at cabinet level. No information has been communicated down. Therefore, everything is being held up there. But the reassurance that we have had is KDF are taking over KEMSA for a short time to normalize the institution. You know, the consumers, I believe, you know, the experience that you have had with KEMSA in the last 6 months have not been very nice. You are aware that the feed-in rate was at 18%, which was, is not anything to talk about in this country. The turnaround time was 46 days for an order, which is also not very nice, because we are imagining if you order a product today, you receive it 1.5 months after. That is not very nice. The reassurance that we have, KEMSA is going to revert back to civilian operation. That is the reassurance that we have. Anything beyond that, I don't wish to be quoted. Thank you.
Thank you, Dr. Macharia, and I also put a full stop on that one. Now, we are going to close up this session. I see Ken picking up the mic already. Aha, he's taking this question. Thank you. Kindly read it out from the audience.
Will we get the revised SOPs following the improvements of the app? From the initial time that we gave out, we developed the standard operating procedures to guide the CHVs and the Chvs on using SysTalk. There have been some developments that have been done. So in short, we acknowledge that we have updated the SOPs. We're in the process of arranging on how we print and deliver them. So they will be delivered at county level, and then the county will be able to arrange on how they go up to the child level. I think that is.
It is straightforward. So with all the updates, all the developmental evaluations, all the waves, all the improvements will be consolidated now, and as part of sustainability and handover, that will be given to the counties. Asante Ken. Thank you everybody for that session. The doors are still open. We are still online. If anyone needs to type in questions, please type them in and we'll be sure to get back.